So this is a post-hoc analysis focusing really on NPM1-mutated patients receiving caveat therapy. And what caveat was a clinical trial run in Australia where we combined Venetoclax with intensive chemotherapy, and this was done in older patients who are fit enough for intensive chemotherapy. And the reason why we really focus on the NPM-mutated subgroup was because multiple studies have now shown that older patients with NPM-mutated AML who are supposed to do well, unfortunately, even with standard chemotherapy, they do quite poorly. So we thought with the addition of Venetoclax to the mix, let's have a look and see what the outcomes are. So from a clinical perspective, we saw really high remission rates with a overall response rate of 85%, median survival over 3.5 years. And what was really interesting was the correlative studies that we could do as part of this clinical trial. So we have a pre-phase with just Venetoclax alone on the caveat trial. And when we looked at the change in bone marrow blasts just after 7 days of Venetoclax, the NPM1 mutated group had a median relative reduction of 66%. And that is just with 7 days of Venetoclax alone. So showing that just with a single drug, you are getting some anti-leukemic activity. And when we then add in chemotherapy, we saw really deep MRD negative responses. So at the end of one cycle of just induction, 35% of caveat NPM1 mutated patients had undetectable NPM1 MRD, and this is by really highly sensitive assays. As we follow these patients longer term, unfortunately, some of them do relapse. We had 8 patients who had treatment failure, and what was most striking about our observation was that 75% of patients, so 3/4, had undetectable NPM1 or NPM at really low levels at time of relapse, suggesting that caveat therapy has successfully eradicated or suppressed the NPM mutant clone, and now they are relapsing or failing with other mutations. And perhaps that may suggest that in patients receiving Venetoclax and intensive chemotherapy, that NPM1 MRD may no longer be as reliable or as stable as we thought they were. And we also saw really interesting observations for patients who fail on caveat therapy. We saw lots of non-genomic changes and a common theme of upregulation of other non-BCL2 pro-survival proteins like Bcl-xL, MCL1, and BFL1 as well. So these provides an opportunity for us to study them a bit more and look at how we can then rationally combine other targets to our combination to prevent resistance.